So thank you very much. Really, always a pleasure to be here. I'll start off. I'll take just few extra settings. I have a prize end of the talk. If anybody can guess the connection between that cartoon on the left in the next 45 minutes to what the hint is, it will have a connection with all of us in the next 5 years, almost all of us, and certainly in the next 10 years. Very difficult one, but if anybody can guess, treat tonight at ITC. Okay. So I think we have had a lot in 2022 in triple negative breast cancer, but needless to say, we have to start with immunotherapy and TNBC, and of course we have to start with the key abstract of pembrolizumab and 5T2. We saw this very interesting pathological CR and event-free survival difference, and that was statistically significant. Let me start with Dr. Chetan Deshmukh. Dr. Deshmukh, do you think this is changing standard of care?
Yes, certainly.
Certainly. Anybody on the panel who is still reluctant to prescribe, and of course cost is no concern, reluctant to prescribe immunotherapy in triple negative breast cancer in the neoadjuvant setting at the moment? Anybody in the panel? Any big controversies in the audience? Okay, Bhavna is not yet. Please, Bhavna, please.
So I think we really have to individualize. It's not just about cost. It's also about long-term side effects as well. Things like endocrine side effects, hepatitis, which then ends up with long-term steroids leading to fractures, leading to pneumocystis carinii pneumonia. When you've treated enough patients, you've seen that. And if you leave a lady who has a very high chance of being cured, let's say T2 and 0, and then you've given immunotherapy and she's ended up in a wheelchair, I think you don't forget these kind of things.
So I think there's fair to say that there is still some reluctance because we're still not as experienced with the immunotherapy yet, but the first time that we have seen some data. You're trying to say something.
So, Nitesh, should we conclude that everybody here prescribes immunotherapy in the neoadjuvant setting?
No, I asked anybody in the panel is actually reluctant yet or not. You're reluctant?
So actually, because the PCR, which we are considering a surrogate marker previously, but now PCR, because with immunotherapy as a neoadjuvant setting, so there is a very good effective immune engagement. So it is far more than the tumor shrinkage and PCR. So PCR may not be a very good surrogate marker. And
yeah, so we'll come to that discussion, and I can request everybody to speak into the mic. We'll come to that discussion, but the point is, despite of everything, Bhavna made very valid points. There is a survival advantage which takes into account long-term detriment, at least in terms of life. There is something to say that adjuvant pembro or placebo could be started with radiation within 2 weeks. Any experience of using immunotherapy? Atul, maybe, I think, were you a part of the trial?
Not this one.
No? Okay. No. Any experience of using it with radiation?
No, till now I haven't used it in breast cancer.
Okay.
Only in kidney cancers. Another thing is that the amount of benefit that we are getting, of course, that time capecitabine was not the standard of care.
So I'll come to all those points. So let me come straight to this point. Yeah, now carry on, please. Carry on. That's the point you're trying to make.
So at that point, capecitabine was not the standard of care for those patients who did not have path complete response. Even olaparib data was not there. So there are 3 agents that improve, that have shown that EFS increases, and OS also increases definitely with capecitabine. The amount of magnitude, if you look at, capecitabine is in the range of, for the triple negative subset, it was in the range of 12 to 13%. And if you look at olaparib, it's in the range of 4%. Although it's a cross-trial comparison, I would agree. But these are all the agents that we need to, I think we are further in the process of identifying where to fit in each one of them. So no, for all patients, immunotherapy, I don't think it's a right choice. For early patients, I would rather say that we need to identify which are those patients. So if there's a patient with T4B N2 disease, and in such a patient, I might go ahead with each and everything that's available. Right?
Okay.
But for a T2 N0, I may not.
Dr. Gaurav Gupta, can I take your view on, I think this is the burning question, that when the control arm was set, we did not have capecitabine, we did not have olaparib, and so in that respect, do you think that these curves would be different had we applied curves like this at the present time?
Yes, so probably with these adjuvant therapies, the outcome does improve. So, and these trials have also shown that achievement of PATH CVR, it might be independent. I mean, the effect on DFS is independent of the PATH CVR.
At least with immunotherapy,
so
that seems to
at
be
best
the
we can
case.
take that as a prognostic marker and maybe escalate the therapy. So that could have been the thing.
Dr. Salil Patkar? Dr. Salil? Okay. Can I have Dr. Muksud, your view on this? Dr. Muksud, can I give a contrary view? So there's a lot of debate that actually the baseline curve may have shifted, but what we don't know is that would that change the whole picture? So this is a lot of conjecture. We have finally data that there is a benefit. Would you not just go by that and still add maybe whatever else is required at the end of the day?
So from this trial,
Could you speak in the mic, please? Yeah.
from this trial, it's better to add immunotherapy in neoadjuvant setting and in adjuvant setting. And I think we can add in adjuvant capecitabine also along with immunotherapy.
Okay, Dr. Krishna, can I take your view on this?
So, see this, I would just go with the panelists. See, we all know that TNBC is a heterogeneous disease. It's not one, and we know that there is enough molecular profile and not all patients are going to respond equally. And there is enough data to say the response, whatever scoring, whether it is validated or not, we all know that the amount of residue is going to translate into the disease-free survival. And and we know in India, most of the patients are going to land up with a large bulky tumor. So trying to get anything and everything at it to get maximum response, number one. And number two, we also have enough data to say even those who didn't respond and get a PCR, those who got immunotherapy had the benefit because of the other effects of immunotherapy.
Absolutely.
So I think PCR is just not the only criteria, but we would, if given a chance, I think we should use it.
Okay, okay. Dr. Prashant?
Yes, so between all these trials of neoadjuvant immunotherapy, the most promising one is 522, and the adjuvant setting, they have not used the standard of care capecitabine or even BRCA, olaparib, they have avoided or they have not used those. So I am not convinced about the role of adjuvant setting they have used.
Let me come to that. So I'll pause you there. I'll put up a very interesting, maybe this is not breast cancer, but I'll still put up a provocating few slides and really question whether the main effect is adjuvant or neoadjuvant. I'm still not sure. Which comes from the lung data as well, and we can see that the pathological CR, this is lung, and the neoadjuvant had a significant separation of curves. And I was and I think if anybody has not seen this, please do say this. This is not breast cancer. But this was a very interesting proof of concept at ESMO in Paris this year, where Dr. Patel was studying melanoma, and all she did was to question whether it's basically neoadjuvant or adjuvant, and the role of lymph nodes before surgery in immune responsiveness in the long term. Just separated 3 cycles of pembrolizumab before surgery versus all of them after. So all of them after versus 3 cycles before, and that was the separation of curves. And I thought that was a very big proof of principle that said that maybe in immunotherapy at least, a lot of effect in principle, this is biological, this is not breast cancer, was before the lymph nodes were taken out. So in that respect, I ask this question again. Maybe I'll just start from Dr. Extreme left. Dr. Sareen, do you want to take this as well? What is the role of immunotherapy in getting pathological CR as well as in residual disease, considering that the lymph node involvement is very critical?
I think that gives a very different new insight into the mechanism of its action, and even the tempo of the response, how quickly you get the response. I think that's what you are seeing in both of them. But here you are looking at the survival.
Because
So lymph nodes are intact in melanoma. Of course, melanoma is a different disease also.
course.
That's
But we saw 3 trials today, and
Yeah.
we of course one we did not have long-term data, but we saw durvalumab had a almost identical, and I'll just show that EFS.
Yeah.
Can we pass it on to right as?
yeah.
Yeah, so I also think the PET-CR role for the immunotherapy is definitely there. And in the neoadjuvant setting, I think it has the role in the breast.
Okay, Chetan.
Except Atizo, both durvalumab as well as pembrolizumab, both had shown a fairly good PAT-CR. They've achieved a fairly good PAT-CR.
Yeah.
So that's
So
that is the purpose of NACT, right? One of the goals of NACT is to achieve a good PAT-CR. That's also going to single out your patient who's going to do well,
yeah,
who's
but
not going to do well.
we will obviously very soon in next 5-7 minutes talking about carboplatin and PAT-CR as well. So your question will remain to be EFS rather than PAT-CR alone.
Yes, but even in that subgroup where PAT-CR was not achieved, even that subgroup showed a better DFS with immunotherapy.
Okay, so let me summarize what we are saying so far. Most of us are accepting that as we get experience, immunotherapy in triple negative breast cancer in the neoadjuvant setting at least is there. Pathological CR is an important marker. We believe pathological CR possibly increases with at least pembrolizumab in the way it was delivered here, and pathological CR has an impact on that. With that, I think we'll go to the next question and the next person on the panel, which is the role of residual cancer burden. This was very well elucidated. I thought this was very interesting how the pathological CR obviously had an impact on the IA4 EFS, and the RCB2 had the biggest impact, but not RCB0, not RCB1 towards RCB2, not RCB3. Any views on how RCB was connected to the role of immunotherapy? Yeah, I think we'll go right from after Dr. Chetan. You have a view on that? Anyone can take that, please. Anyone else has a view on that? Any explanation in the panel? Dr. Maniar?
I mean, RCB3 were very small. That group is barely 40 patients, I believe, less than
And that
10%.
was maybe so poor prognostic
Yes.
that nothing impacted.
Yes. But RCB2 alone is...
Atul, have you deep dived into this?
I agree that number was low, but I think that's somewhere in the middle. The RCB3 was too bad and that was too good. So probably that could have accounted. But
Can I ask anybody in the audience if they have had a chance to deep dive in why did, I think Sudeep, you have a view on that, why this discrepancy where RCB0 had no view and RCB2 had a clearly big separation of curve, and this was pre-planned analysis.
So I'm not certain about this. It is possible that patients who have a complete pathological response, once that state is achieved, the prognosis is more or less similar, whatever you do beyond that point. As to the other RCBs, whenever we analyze these data, one should always be cognizant of the fact that the more you slice and dice the data, the chance of artifactual results just by the play of chance is the single most important explanation for anything that comes up.
Possibly, that we had a bigger volume in RCB2, so.
Because, the numbers, these are not randomized groups. They are not balanced with respect to baseline factors. So, then any result is possible.
Okay.
Just a thought. Have they looked at the RCB1? Is there a data for that?
So they looked at RCB 0, 1, 2, 3, all separated, pre-specified. Yeah. And RCB 1 did not show a difference. RCB 0 did not show a difference, as I've shown. RCB 3 did not show. RCB 2 clearly showed a big separation and massive separation. It almost seemed that the entire data was driven by RCB 2.
What was that? Is there how much difference between RCB 0 and 1 and 2 in the treatment arm?
That we'll have to check. Sorry. So the question becomes, is there any, please.
So even when I was going through this paper, the only thing like what Sudeep sir mentioned, if you take the extremes of the group, probably the ones who achieve 0 and 1 are so chemosensitive, and then any addition of further didn't make a meaningful difference. And probably the same story holds good the other way. When you have a disease which responds pretty badly to both chemo as well as the pembro.
So the only logic that I was thinking was that maybe the middle RCB were causing enough antigen stimulation to cause some immune response, while not the other RCBs. I think Sudeep wants to make a point, then we'll move forward.
So I don't know the reason for this, that is only speculative, but I think this data tells me that it may be okay to stop pembrolizumab if somebody has achieved a PATH CR, because even without pembrolizumab, the outcome is so good.
So that's
so once
exactly
you've
my
gotten
next
to that
question.
point, then this data tells me that maybe one should, it may be reasonable to sort of not continue.
So that's the next question. Atul wants to take this up, I think. Should we stop?
But that's very counterintuitive from the durvalumab trial if you look at. While there was no difference in the PATH CR, but there was difference in the EFS. Although I agree the number of events are less, 12 and 22 if I'm not
that's
wrong.
your graph there.
Yeah, but still that's very thought-provoking that what are we stopping at PATH CR is what we are looking at only the breast and axilla. What's happening outside?
Or a
probably we
contrary
don't know.
view is that these are independent, and we have learned to correlate that through our 10 years of learning. We have spoken so much about pathological CR and survival that we are not realizing that there is an immunotherapy which has a long-term effect related to how much tumors that we are killing, and is an independent effect on the pathological CR. So you're trying to say
Would be
something.
interesting.
It is also possible, we always felt our immune system really clears the last few cells. It may be that the RCB2 is where the immune system cannot clear, but at the same time this addition will make it clear. RCB1, immune system clears it all.
Okay, I think we'll stop about RCB, otherwise we'll keep going on. We have some very interesting data, but essentially what you're trying to say is that Durva showed very similar results in EFS without an effect on pathological CR, but this was not as strong numbers as the keynote study. So this was again in response to the fact that this is toxic. Back to Bhavna's point, it's not that it's without toxicity, and it does raise the point, at least to my mind, whether the adjuvant continuation of immunotherapy, especially in patients who achieved pathological CR, is relevant or not. I'm not so sure about the patient with RCB because there is clearly a very big separation of curves there.
How do you choose about patients who do not achieve a path complete response?
I think what I'm trying to imply, at least that's what my learning is, please, we have a very learned panel here, that if you're starting in neoadjuvant, and anthracycline role is very important here.
Absolutely.
If you're starting with neoadjuvant therapy, if we are using platinum along with paclitaxel weekly, maybe all of these are playing a role in antigen stimulation, in causing immunotherapy, in EFS, and you're still not achieving enough pathological CR. If you have RCB, and we don't know what RCB 123 means, I think that's fair. Considering that the separation of curves are very large in that group, I feel quite compelled to actually continue there rather than in the patient with pathological CR. That's my view at the moment.
Yeah, absolutely agree with that. But I was just asking about the other options that you have in patients who do not achieve a path complete response. Like, would you consider? You would be asking us those questions. Rather, I'll put that first to you.
Okay, so let's start with Dr. Rohit. What about you, Gaurav? Sorry, Gaurav. What about you? Would you add? I think you are asking, would you add capecitabine to this, or would you add olaparib to the immunotherapy if you don't achieve pathological CR?
So especially with this durvalumab trial, they had allowed adjuvant treatments. This is what I understand. Not durvalumab as adjuvant, but the capecitabine, etc., were allowed in those.
At least I am not aware of that. Anybody in the panel aware of whether capecitabine was allowed or given? I'm not aware of that. No, at least not that what I read. So
it was not allowed, I think so.
So
but in Durva, probably.
It may have. I don't think they.
One of those episodes.
So would you give it though? Would you give capecitabine to patient with residual disease?
Yes,
would you give
I
IO
would
and capecitabine?
I would consider at least.
Okay. Dr. Manyar, would you?
I would absolutely. If I have not achieved a PATH CR in spite of neoadjuvant chemotherapy and immunotherapy, I'll be very uncomfortable.
Okay, and BRCA positive? Okay, and Dr. Deshmukh?
Yeah, I would change my plan. We do it in HER2 positive disease. If you don't achieve PAT-CR with TRAS2 in the NACT, you change over to TDM1. So that is, I would apply the same principle that if my frontline therapy hasn't done the job, it makes sense to do something different in the adjuvant setting.
Okay. Dr. Prashant?
Yes. So regarding adding capecitabine as adjuvant, those are being
So
achieving PCR.
if you have residual disease, if you are planning to give immunotherapy, would you add capecitabine as well?
So though in the trial setting they have not used capecitabine, but because it is a standard of care, I will use capecitabine, and in BRCA positive cases, olaparib can be added in addition to the pembrolizumab 1 year.
Okay, so it seems that without clear data on this, particularly because the trials were not done at the time when this was there, many of us are comfortable using the combination. I am slightly reluctant, I'll say that, because I don't know what the interaction will be of these drugs, at least in the long term, at least as a combination. This is not metastatic setting, as Bhavna actually quite rightly put. This is curative setting. We are achieving pathological CR, but I do buy all your points, and I think this is what's happening across the world, where there's a confusion about that. Amit, and then we'll go to the next point.
It is possible that all the benefit in this setting in breast cancer is accrued by 6 to 8 cycles of immunotherapy. There's a possibility.
Sorry, I didn't understand your question.
So it is possible that in a neoadjuvant setting in a breast cancer, the benefit of immunotherapy is completely accrued by 6th, 7th or 8th cycle. Okay? Got a point? So what I'm saying is maybe 6 to 8 cycles of immunotherapy is enough for breast cancer in a neoadjuvant setting.
No,
No, hear me out. Maybe, as durvalumab suggested, that the hazard ratio of both the trials is more or less similar. Suggest
I know
that
where
the
you're
adjuvant
going.
segment, there is no data set obviously.
I know where you're going. You're saying stop
it's the
stop
same thing
there.
it's the same thing being said again. What I'm trying to say is, so maybe a limited amount of immunotherapy does whatever is to be done, either in the form of an excellent response like PAT-CR, or an RCB1, or an RCB2, or an RCB. That's what it can do. Maybe incremental immunotherapy in adjuvant phase cannot achieve anything more than that. It's a possibility. Now let us say the adjuvant immunotherapy trial, which are going to be reported anytime, are a failure. Adjuvant immunotherapy trial turns out to be failure.
Okay.
Then we will be more confident that whatever immunotherapy that we have given during the pre-surgical phase possibly suffices, whatever the result may be.
Okay.
Am I clear? No?
So
instead of 1 year or 2 year of immunotherapy in many other settings, for example, lung, we require 1 year of atezolizumab, correct?
So Amit, I buy what you're saying. I'm not denying. All I'm saying is that in a curative setting, when the data is lacking, I think you could argue that these RCB patients are very poor prognostic, but when the data is lacking, you have to have full disclosures with the patient and be very clear that we really don't understand in a curative patient, these are still curative patients, what is the toxicity that we should expect and what are the numbers there? We are conjecturing as I understand it.
So if we talk about lack of data, then you can't add olaparib or adjuvant capecitabine because there is no data about how capecitabine and olaparib functions.
Yeah. So I'm not saying what we do, I'm saying what one should do.
So they will never be a randomized trial, we will have to extrapolate now.
I agree, and I think so we may end up doing that, and that's what clinical setting is. You end up seeing a patient who you feel is extremely high risk, you're very nervous, and you end up taking some decisions which are out of the box. Okay, I'll go on. In summary, pathological CR versus EFS, I clearly feel EFS is more important, but there's some interesting data on EFS more important than pathological CR with IO. I am not sure. Anybody on the panel who can answer this? Could this be interaction between PD-1 versus PD-L1? Duration of neoadjuvant chemotherapy, if you were to use that, the right chemotherapy, role of anthracycline, any biomarkers, and effect of germline abnormalities. So last few questions on immunotherapy. Can I ask anybody in the panel to take these questions, or few of these, whichever you want to take? So
role of anthracycline.
Dr. Sareen, why don't you start? Effect of germline abnormalities on immunotherapy in triple negative
We
breast
know
cancer.
that if there's a mismatch repair germline mutation, especially MSH2, you can have breast cancer, about 15% risk in germline MSH2 carriers. So if they have the germline, normally we don't test for this, but when we do testing, in our cohort of few hundred cases, we did germline, we find MMR gene mutation in about 8% cases. Those who have a germline mutation.
And they're tending to do better in terms of getting more pathological CRs and EFS.
So they haven't had, very few of them, or rather I would say none of them had immunotherapy, so I can't comment on that. But this is well known in general in cancers that those who have a germline mutations, they do better.
Okay. Dr. Deshmukh, any biomarkers that you can use other than PD-L1 22C3, or would you only test for that if you had to use immunotherapy?
Oh, none.
Okay. Role of anthracycline, yeah, please.
Yeah. So, regarding role of anthracyclines in clinical practice, I think still we've not reached a stage to eliminate anthracycline. So, whichever we are going to sequence, anthra will either come in the beginning, or if you're going to use it as per the
so that was paclitaxel followed by anthracycline followed by surgery.
Yeah. The second thing is biomarker. Newer biomarkers aren't there, but there is data to say that if you have enough biopsy tissue and if you find a good quantity of TIL in the preoperative or pre-chemotherapy specimen, you know that these people are going to probably respond well. And our candidates
that's irrespective of immunotherapy. They may generally do more pathological CR.
Even with routine chemo, and that was what we saw in the other arm, the patients who didn't receive immuno, why they had a good CR rate.
I am running short of time, so I will go on to the next big question, which is carboplatin, and we'll start. Is Dr. Jimmy there? Dr. Jimmy? Okay, so we'll start with you, sir. Long-term efficacy of addition of, this was the brightness study, and this clearly showed that platinum had a response, as well as that there was a clear effectiveness of pathological CR on survival, irrespective of mutations. Your views on that?
Yeah, in the addition of the carboplatinum agents, it will give the better response rates and give the better chances for the PET-CR. So we generally use the carboplatinum in the young age patients specifically.
Okay, okay. Dr. Maniar, can I take your view on that as well as the difference in 40603?
Platinum is probably most of us have now inculcated it in our triple negative neoadjuvant journey. I wanted to use this platform to ask one question if I'm allowed to. If you have a T1N0 triple negative, the patient has been operated upfront and now is sent for adjuvant setting, do we all would still treat the patient in the same way?
So that's a question on adjuvant versus neoadjuvant strategy, and I will exclusively ask this question to Dr. Batra because he has worked on it, and I called him last night and I said, what was the interaction? Why don't Atul, I pass on to you? What was, so I really want to understand, because this whole meta-analysis, which was very interesting, was driven mainly by studies in the neoadjuvant setting. But you have actually extracted data from the two key trials which are adjuvant as well. And could you opine and give us some feedback on that?
So one, there's no, I think we all have agreed that we are using carboplatin now in neoadjuvant setting.
Okay, so have we all agreed that carboplatin in triple negative breast cancer neoadjuvant setting, all T, all N should be used? Is there anybody? Hands up, please. Bhavna is also not put. No, Bhavna is a big believer from time immemorial. Anybody on the panel? Okay, so I think we can safely say, we don't need to put hands up. Everybody agrees now that Sudeep and I have had discussions on this, I don't know, long ago, many times. Amit?
Neoadjuvant.
Neoadjuvant, we're not talking adjuvant. Neoadjuvant, triple negative, breast cancer. T irrespective. Yeah, of course, you're operating first. I'm saying if you need to give neoadjuvant to any patient in triple negative breast cancer. Okay, Atul, carry on.
So in this, we didn't find any interaction between neoadjuvant setting or in adjuvant setting. There was no interaction. That means that but most of it is, we know that most of the data comes actually from neoadjuvant trials. The only thing was that none of these trials were actually powered to look for EFS. It was mostly PCR driven. And it was all the combination and then the trial published by...
So how do you answer two questions for me? Question number one, in terms of neoadjuvant, I think we all accept that carboplatin, where it can be safely added, should be added. I think we had a fairly nice presentation on when added, please consider giving it on a weekly frequency so that you can maintain doses. I think that's a very good point Priya brought up. But the question is adjuvant therapy, and I think that's what really Dr. Maniar is asking. Is this data strong enough that if I get a post-op patient with high-risk features, let's say node positive by chance, would you consider platinum in the adjuvant setting? Is the panel split on that? Can I have a show of hands, not of the audience first, or the panels who would consider post-operative T2N1 triple negative patient for carboplatin?
T2N1 for sure. The worry is T1, T2, N0.
Okay, so T2 and 0, triple negative breast cancer in the adjuvant setting. Carboplatin,
Actually,
yes or no?
this question can be better answered by a trial, ongoing trial, NRG trial. So they have a arm with carboplatin in the adjuvant setting. So that will better answer our question regarding this query.
At the moment, would you add to adjuvant T2 and 0?
Yes, I'm skeptical about. So in high risk case, I'll going to add.
Chetan, sorry.
So the question is, if you have to select between dose dense AC and paclitaxel versus incorporation of carboplatin anywhere, what the panel will select?
So I think it's fair to say that considering we can easily use weekly paclitaxel, I don't think that will change. Can I have an audience poll very quick? Adjuvant T2 N0 carboplatin, how many would use? N0. T2 N0. T2 N1, how many would use? Triple negative, all. Sudeep, you're saying something. Huh?
But you know...
Adjuvant.
But Nitesh, I wish to say that, we are talking more or less in a data-free zone just now. So, at the current time, there isn't a good level 1 evidence to say that we should use carboplatin, for example, in preference to what he said, dose dense AC paclitaxel.
We don't have. That's exactly what I'm saying.
So the point is, these are all opinions of whether we will give or we will not give. The data on platinum is essentially from the neoadjuvant
only.
setting. I mean, adjuvant, there are small scattered...
There are two studies which...
data, but as he correctly pointed out, there's a large NRG study that will report this year. So I think we should wait for that study to see what it says, because we cannot completely extrapolate from the neoadjuvant to the adjuvant setting.
I completely agree.
So in this sort of a situation, he very correctly pointed out that if you give paclitaxel and carboplatin, then you can't use dose dense paclitaxel in the or docetaxel in the doses that you would otherwise use.
I agree. But I think more importantly, even if I could, I am reluctant to do that in the adjuvant setting right now, because I don't feel we have enough data. I think neoadjuvant, it's taken me a while to get convinced, truthfully. I don't think even I was convinced till 2 years ago, but now I am. But I think in the adjuvant, I am not yet convinced. Amit?
I actually have to ask a question which is slightly different, which includes Sudeep also. In your analysis, did you see what happened to people more than 50? In your analysis, did you see what happened to more than 50?
We didn't find any interaction between age and this thing, but it was very clear in that trial that was done.
No, I agree. But in your meta-analysis?
We did not.
You did not. So, obviously, we have to find that. Second thing was, why more than 50 get harmed?
Yes, I'm coming to that.
So why did more than 50 had
Amit,
worse PFS?
Amit, we haven't reached there yet. Yes, okay, thank you. Okay, so next question. And I think this was really kudos to Sudeep and the team and Tata. This was really a fantastic study, clearly showing a difference. And I think the big question, and I'll start with the panel again, maybe Gaurav, you can start here. Why the difference in age? And this is very interesting, and I think we have to delve a little bit on the fact that all women who had pathological CR had a benefit. Let's start with you, then maybe I'll take Atul's and Dr. Mania's, all of your opinion on why there was an age difference and what do we do in clinical practice now.
So I just wanted to ask, sir, whether we saw the compliance, but number of dose reductions within those, was there any difference? Like the number of cycles was quite similar.
So we have studies from before where
Dose
paclitaxel
reductions-
dropped, decreased efficacy in terms of adjuvant study. Yeah,
So
sorry.
actually in older and younger patients, there was no difference in the number of cycles, there was no difference in the dose intensity. There was also no difference in the cumulative dose. If you can go to the either this, both for overall survival as well as for event-free survival, there's a clear difference. And if you look at the brightness study, then in the supplementary appendix, they have broken it down by age. And again, the diamond for the older women is near to unity. You'll not find it, it's in the supplementary appendix. And if you look at the CLGB study, there again, they have taken age groups of less than 40, 40 to 60 and more than 60.
Yeah.
And again, the older women are, the ones where the diamond is either at unity or to the right of unity. There is an age interaction, and we also have seen that there is an age interaction in the TaylorX trial, in the RX Ponder trial. There is clearly something to age which we, do not sufficiently understand.
But how do we put that to practice? I appreciate 75 and 55 are different, but how do I put a 55 or a 60 in practice?
So now the problem is this. You see, I'm completely convinced with the data because I have analyzed this like 50 times that, older women do not benefit from addition of platinum. Now, where that age cutoff is, I don't know. And Dan Hayes, just after my presentation, came up to me and said that you should do a step analysis. So, you should take different cutoffs of age and then see where the benefit vanishes rather than just taking one cutoff. And I think that's a good suggestion which we are implementing while when we publish our paper. Hope said that it is highly likely that the older patients actually have a non-basal type of triple negative breast cancer, or at least there's a higher proportion of those patients.
I felt there was a germline predominance somewhere, maybe.
Andrew Tutt, he also walked up to me and he said that maybe there are epigenetic modifiers of BRCA that are more active in the younger individuals compared to older individuals. Now, so but if you look at the brightness study, clearly the benefit is regardless of BRCA.
Yeah.
He just showed that. He just showed that analysis.
It is.
But Amol, even in the GEPAR-62 study, the benefit was actually regardless of BRCA. So there are actually other pieces of evidence, not from our trial, that this is not due to BRCA. Yes, right there. If you see platinum versus not, regardless of germline BRCA mutation status, there is a big difference.
Yeah, but then, there is some epigenetic factor
So now
there as
I
well.
will tell you the other comments at San Antonio were that in societies where in the neoadjuvant setting, pembrolizumab has become the default standard. Because pembrolizumab has used carboplatin as a backbone, so therefore it has become the default standard regardless of age. But I'm convinced that when one is not using pembrolizumab, perhaps for the older age group, now where you take the older cutoff 50, 55, postmenopausal, whatever is different, but our data clearly shows that there is something to age that makes for a lack of benefit from platinum.
So that's reassuring. I really spend a lot of time to understand. If you can't understand, I'm reassured by that.
Why there was harm in more than 50?
So there is no harm if you look at the overall survival is the same, and if you go back to
EFS, yes.
No. Next slide.
Sorry.
And stay
this one. No. The previous one. Yes.
Stay there.
No, the previous one. EFS by age. Previous, yes, right there. So if all of you see the control arm survival in more than 50 is over the platinum arm.
Yes.
So it's better.
But this is not a statistically significant detriment, and if you look at the numbers at risk, you see there are almost close to 500 patients who are younger than 50 years of age, but there are only about 200 and some patients who are older than 50. So there is also a lack of precision around those estimates. So one can't be completely certain, but what one can be certain about is at least there is no benefit.
Yeah, but the curves actually look inferior. I mean, I agree with you, but
Yes.
the question is about the numbers. Had the numbers been double, these curves would have possibly meant the same thing. If you see, this is basically explained by the fact that people at risk were much lesser in elderly population. Actually, saying more than 50 is elderly is very bad. But still, if these numbers were doubled, if the trial was run more than 50 with 500 number, this much of curve separation.
So maybe these would not be the curves if the
Yeah,
numbers were
yeah,
higher.
yeah.
True.
That's
it may
the whole
be
meaning of statistics.
Completely agree, completely. But it may be a good idea to go to KN522, that new adjuvant pembrolizumab, go to supplementary. I mean, I'm not asking you to do it. Maybe even there is a correlation between the age and that the pembrolizumab works
And join
more for
the
less
data.
than 50.
And join the data. But I think that step analysis will help. I am running very short of time, but this was very interesting. So there was absolutely no way we could have stopped this. This really changed our practice. So thank you. Very quickly, back to the panel. I'll start with Dr. Jimmy again. GYM2 long-term follow-up. These are very interesting studies. Essentially, we agreed dose dense is a good no 5-year view in the adjuvant setting, 3 weekly versus 2 weekly, and if you agree, then what do we do about this? Dr. Jimmy?
What we generally do in practice, we use the dose dense regimen.
Okay, Chetan, if you had to use immunotherapy, would you go to 3 weekly or 2 weekly? Because it was 3 weekly in the keynote 522. And we have already said that actually very long-term follow-up data, 2 weekly or weekly schedules are better.
So with immunotherapy, it's 3 weekly. There's no.
Yeah, so it's 3 weekly.
Yeah, so it will have to be 3 weekly. If
Okay.
you're good.
Yeah, agree with him.
So,
If no immunotherapy would go with 2 weekly.
I might
if
do
we
it
know
2
and
weekly.
we want to stick to it, it is 3 weekly.
I might do it 2 weekly. If
Okay, okay. So this is very interesting.
We can have chemotherapy 2 weekly and pembrolizumab 6 weekly.
Okay. Okay, so we.
I would also give a dose dense chemo 2 weekly, but Pembro again, 4 weekly or 6 weekly. Yeah.
So I think what this is showing is that, and I agree that it is very difficult to leave data which is, you're talking about an end of study over a decade or more, and showing clearly benefit of dose dense and dose intensity, to be fair, is very relevant. So I would carry on with that. I think we'll skip this. So will the delta being seen mainly in the dose dense in the hormone receptor negative population, not so much in the HR, although it was 5%, that's relevant. How would you take this in terms of adjuvant CDK, adjuvant PARP inhibitors, and I will come to PARP inhibitors in a minute with Dr. Sareen as well. So can I have Dr. Manyar, maybe your views on this, your view on HR positive dose dense chemotherapy in node positive obviously patients?
Dose-dense chemotherapy in this population, unfortunately, I do not use it very honestly as a standard of my practice at this point of time, because we are not chasing a PAT-CR and these patients will irrespectively do well. Regarding adjuvant CDK4/6 inhibitors, the monarchy data is there for all of us to see.
Okay.
Very honestly, it's not yet standard of care for me, because mostly me and my patients, both of us get tired of the abemaciclib-induced diarrhea by the time we reach 4-6 months.
Okay, Dr. Sareen, I have about a minute and a half left, so I'll go through a couple of last questions. This was very interesting. This was the overall survival of Olympia, BRCA and high risk. This is the I4 study. Where do you really see the recommendations where we should not be using? Because there are clearly some curves which are crossing the midline.
So I think we know the patients in this trial, from the population of patients who did not had a response. So they were early stage cancers, and those who had a PAT-CR, they were not included in the study. So obviously those patients, and there is a subset of such patients. So, and where you are considering other forms of therapy or IU and all, whether there will be additional benefit of olaparib or PARP inhibitors.
Okay, anybody else in the panel, please, can you take some questions on this? Where would you not use PARP inhibitors as standard of care. Atul?
I'm still using capecitabine only, no PARP inhibitor. So
There are a couple of groups there. I think we'll have to dissect more. Possibly we'll need a few more sessions for that. But there is clearly the 355 was very interesting. There was a benefit, but only in more than 10% CPS. And that does bring up the question of which chemotherapy, which biomarker, and what to do. So I think I will have to end there. Thank you very much. I have skipped something, but it was very interesting, and I must thank my very learned panel for that. And thank you for the audience for having it. Thank you.